I'm going to introduce Dr. Nate Collins. He's a second-year resident who's going to be talking about to tube or not to tube. That's the question. Should healthcare providers perform endotracheal intubation during non-traumatic cardiac arrest?
Thank you. All right, so this is a pretty useful topic in terms of our daily life. So different airway devices we have. There is the rescue breathing, where you're taking one person, breathing into the other person, and you can actually deliver 16 to 17% FiO2 to the patient. And additional devices include the face mask, where you have the traditional face mask, and a couple of supraglottic airways, the laryngeal mask and the combi tube. And then you have the more invasive airway, which is the tracheal intubation. Other than the face mask, the airways, the devices that you would put into the patient, essentially, all take time, and time is tissue. So here are the examples of the different airway devices. You have the face mask and the bag valve mask, which can be essentially administered by a lay person, as opposed to the supraglottic airways that include laryngeal mask airway and the combi tube. And then for more trained people, you can do the endotracheal tube. So kind of going off of what Dr. Freed says as far as the history of CPR, in 1956, Peter Safar and James Elam started mouth-to-mouth resuscitation. In 1960, Dr. William Kohlhoven discovered that chest compressions alone could sustain life while awaiting definitive care. The two came together and created CPR. Here's a paper in 1954 by Dr. Elam, who was performing mouth-to-mouth on post-operative patients who were under general anesthesia before they went to recovery. And mouth-to-mouth resuscitation was able to maintain oxygen saturation of 90% or higher. Mouth-to-tracheal tube got up to 94%. And then here's a paper by Dr. Kohlhoven, in which he performed closed chest compressions as opposed to classic open chest compressions, where they were actually massaging the heart internally. They were able to sustain systolic blood pressures between 60 and 100 millimeters per mercury when they did the closed chest compressions. And here's actually a case of a gentleman who ended up having an MI, where they performed closed chest compressions and were able to keep him alive until a defibrillator arrived. So the guidelines typically for CPR for cardiac arrest, let me first define cardiac arrest as pulselessness requiring chest compressions or defibrillation with a hospital-wide or unit-based emergency response. This was shown to be in a paper I'll discuss a little later. But classically, we've always done airway breathing circulation as the priority in CPR, and the intended goal when this first started was to try and obtain ROSC, or return of spontaneous circulation, in less than 8 to 10 minutes, because it was shown that after 8 to 10 minutes, the risk of permanent neurologic damage became excessively high. And here's a paper in 1991 that described the chain of survival, which helped implement a protocol for pre-hospital cardiac arrest, in which it showed that early access, which meant calling EMS, education of the lay people to get a hold of emergency personnel earlier, was shown to be beneficial. Early CPR, early defibrillation, and early advanced care. Initially, defibrillation was a part of advanced care, but through various cases, it was shown that defibrillation was actually so significant in the improvement outcomes of non-traumatic cardiac arrest that it became its own chain. And they used intubation and IV medications for advanced care after it was shown that the difference between two groups, back in the day, they used to have paramedics and physicians who would perform CPR on people in the field, as opposed to EMTs who could only defibrillate and weren't able to intubate. So the studies that were shown showed that the more advanced or more qualified people had better outcomes, and they were able to intubate. But this may have not necessarily been the case of intubation, more as the patients were more, or the people who were performing the interventions were more experienced and qualified. So here's a study in 2010 that was a retrospective cohort study of 1,294 non-traumatic cardiac patients in LA who were either underwent endotracheal intubation or bag valve mask prior to hospital arrival. And it was shown that the survival in these patients was 4.3%, and it actually favored bag valve mask patients. Patients who were not intubated had better outcomes. This is a scale in which a lot of studies that have evaluated pre-hospital intubation versus bag valve mask has been made, and it's essentially a performance table in which CPC 1 and CPC 2 are acceptable outcomes, in which patients are able to perform independent activities. So here is a multi-center study based on a Japanese registry of 649,000 patients who had out-of-hospital cardiac arrest, in which they compared bag valve mask to endotracheal intubation. And their primary endpoint was favorable neurologic outcome based on that scale of 1 and 2. 2.9% of the patients underwent bag valve mask and had favorable outcomes. 1% had endotracheal intubation, had favorable outcomes. And so it was significant that advanced airway placement had decreased odds of a favorable neurologic outcome compared to bag valve mask. So is there evidence that intubation does improve cardiac arrest? Well, there has been attempts to try and prove this point. Here's a study on another Japanese registry in which 25,000 patients were evaluated of out-of-hospital cardiac arrest, and they went by the chain of survival mantra and kind of evaluated if early CPR, early defibrillation, early intubation actually improved. This study took place from 1998 to 2006, and during that time, a lot of improvements were made in the chain of survival in this area. They found that 1 month survival was favored in patients who had both early CPR and early intubation. So, interestingly enough, they state that early intubation had better neurologic outcomes. However, the median time of their intubation hadn't changed. It was still 25 minutes. So here's their data, in which towards the bottom, from when the patient collapsed to intubation, you see that the median time did not really change, yet it was stated that collapse to tracheal intubation had a favorable odds ratio. And this may have been due to just improvement in early CPR, and the patients who were intubated. They did not compare early defibrillation in these cases because they were presumed cardiac origin, so they didn't necessarily have two of the shock wave rhythms that we use in early defibrillation. And you can see in patients with initial VFib cardiac arrest, only collapse to early defibrillation was shown to be significant. Here's another study in which 32,000 patients were evaluated in Korea, and it was between bag valve mask, subglutic airway, and endotracheal tube. And again, they were looking at the survival to discharge based on neurologic outcome of CP1, CPC2. And their conclusion was that the overall survival to discharge and a favorable neurologic outcome was higher in the endotracheal group when compared to bag valve mask group. However, if you read on in the study, it shows that the information did not differentiate whether patients were intubated during CPR or after they had achieved ROSC. So that would be a significant variable. Also, the cases that were intubated unsuccessfully were not re-intubated or not put in the intubation group. They were put into the bag valve mask group. So here is a study that shows that the more intubation attempts that you have correlates with worse outcomes. And 1,100 patients were not randomized, were looked at in a registry to determine if the number of attempts affected the survival. And it turns out patients who received no endotracheal attempts had 2.33 times more likely to achieve ROSC than patients who had even one endotracheal attempt. As you can see here on the left side, you have the no endotracheal attempts, and if you go over one row at the very bottom, you see that the percentage drops off dramatically. Here's a very recent study that was presented at the European Society of Cardiology Congress in 2017. It was presented as an abstract on 2,000 patients who were randomized in a non-inferiority trial on 28-day survival of good neurologic outcome. And they found that they were unable to, their results were inconclusive in showing that endotracheal tube is inferior to bag valve mask. So essentially, the results weren't significant. They did comment that they had more complications in bag valve mask in terms of technique and respiratory failure, but in terms of mortality or their primary outcome of neurologic outcome, they weren't able to prove that bag valve mask was inferior. So what about cardiac arrest in the hospital? So this is a new article that came out in JAMA in January 2017 on 108,000 patients who were, it was a multi-center retrospective observational study who matched patients who were intubated and who were not intubated based on a 15-minute interval during cardiac arrest. Their primary outcome was survival to hospital discharge. They found that patients who were not intubated for every minute were more likely to survive hospital discharge and were more likely to achieve ROSC and have functional outcome in all three measurements. Here you can see their data. All of the risk ratios favor no intubation. So the guidelines for CPR. In 2010, the guidelines were changed from ABC to CAB, meaning circulation, airway, breathing. Why did they do that? The highest rates of success in resuscitation are those who have witnessed arrest and are initial rhythm of VFib or pulseless VTAC. The critical elements have been shown that chest compressions and defibrillation are the key elements of CPR. And both chest compressions and defibrillations are delayed when trying to secure an airway, traditionally when you use the ABC mantra.
Okay, so is it a myth? Yeah, questions, comments? So the question was about the differences in favorable outcomes between some of the studies, whether there was as big a difference.
Some of the studies that I showed wasn't necessarily the outcome. It was the proportion of patients that were bagged and the proportion of patients that were had endotracheal tubes.
And nobody has a 90% outcome.
Okay, so the question, is it a myth endotracheal intubation should be routinely performed during CPR? in non-traumatic cardiac arrest, which has been our general practice and probably the general practice around the country, if not the world. I put in here routinely because I think there's certainly cases, individual cases, exceptional cases where you can't bag people adequately, can't ventilate them at all. And some of those people, at least after several minutes, probably you're going to need to intubate them. But not right off the bat, I don't think, until you're sure of that you can't defibrillate them or resuscitate them before that. So anyway, the question is, should they routinely be performed? And I'm sure there's traumatic cases where you have facial trauma or something and you can't ventilate those people. Those people, maybe they should be intubated. But those are really exceptions to the rule, I think. So that's the question, and we will vote. So how many people think that we should continue the current practice of intubating during CPR, and I'm not talking about intubating them after you've resuscitated the patient and gotten ROSC, but during the CPR efforts should be intubated routinely during? Okay. How many think it's maybe we should? Plausible? How many think that there's one? How many think this is busted? All right. Well, then we get to watch it again. Busted, man. We explode the myth.